Ladies and gentlemen, we're going to get started in about 5 minutes, so if you can grab some food and wrap up your conversations, that would be fantastic. Thank you. Good afternoon, ladies and gentlemen. Thank you so much for coming out. My name's Brandon Stevenson. I'm with the California Partnership for Access to Treatment, and this is our Hepatitis C seminar. First off, I want to thank you all for giving us some of your time to hear from Dr. Saab on a very important topic, a topic that we have not covered before, which is one of the reasons we felt so strongly about holding this seminar. Before I hand it over to Dr. Saab, I want to go over just a couple of house cleaning issues and give you guys a little background information on what the California Partnership for Access to Treatment is. So the first thing is the house cleaning stuff. As you can tell from the cameras, we are streaming this event. This is the first time that we have actually streamed one of our events. We're very excited about it. Not only does that mean that people who are not able to come to our event will be able to watch it, but that you and others will be able to watch it after the fact. So if you could be mindful of that and maybe not walk in front of the two cameras, which I've probably already done 5 or 10 times, that would be fantastic. You all should have received packets when you came in the door. On the left side of the packet is a lot of information about CPAT. Very briefly, CPAT is a free health education network that we created to provide information and resources on pressing healthcare issues in California's changing healthcare system. Funded by America's leading pharmaceutical manufacturers and researchers, we put on these events to try and provide all of you with information that will allow you to provide better services to the people that you treat or more effectively advocate on their behalf. So there's a mission statement, a long list of our nearly 1,400 partners statewide, as well as a frequently asked question sheet. On the very front of your packet is a sign-up form. If you are interested in participating in future events, all you have to do is fill that out to become part of CPAT. It's completely free, and we would love to see you guys at future events. On the right side of your packet is not only some information on hepatitis C, but also the PowerPoint presentation that you're about to see so you can follow along with it. At the very back of that side is a flyer on the Partnership for Prescription Assistance. It's our sister program. Someone will be speaking after Dr. Saab on that. It's a program to connect people who are uninsured or underinsured with free or nearly free prescription medications. It's helped more than 6.5 million people, and it's something that could probably benefit the people that you work with. If anyone here is here for CEUs, you should have signed in at the front table and should have been given a survey if you're here for nursing CEUs. Either way, you can see myself or Jesse and Lauren, who are in the back of the room. Wave to everyone. Wonderful. And we'll help you make sure that you get your credits. Parking, anyone that parked down below, we're happy to give you a validation. Just see the 3 of us and we'll take care of that. And one of the most important things were the bathrooms. Out of the room, make a right, you go past the front desk, and then they're down the hallway on the left. So there's all the house cleaning stuff. Before I hand it over to Dr. Saab, you'll see all of these logos at the bottom of the screen. These are all the groups that have co-hosted the event with us. We're very thankful for them. There's the American Liver Foundation, Clinica Romero, Healthy African American Families, Minority Health Institute, and the Wallace Memorias. We love partnering with our CPAT members on events. Not only does it help them connect with other healthcare providers, but it helps promote their name, their mission to the general public. Also want to thank 3 staffers of elected officials who came here, who took time out of their busy schedule. We have someone from State Senator Kern Price's office, someone from State Senator Ed Hernandez's office, and someone from Congresswoman Roybal Allard's office. So thank you all for coming out. We really appreciate it. And then I'd be remiss, Tally with the American Liver Foundation has set up a table in the back of the room with additional information about liver disease, hepatitis C. So if you're looking for additional resources, please stop by that table on your way out. I think that's about it. I think you've heard enough from me. I would like to introduce our main speaker, our primary speaker, Dr. Sammy Saab, to take us through everything you need to know about hepatitis C.
Thank you. Hi, everybody. Hello. I feel like the Verizon commercial. Can you hear me now? So thank you for inviting me to speak today on hepatitis C. It's a great privilege and honor to be here. See a lot of familiar faces and some new ones as well. Now, this is a very exciting time for us in hepatology. You know, for the first time in a decade, wake up, right? First time in a decade, he's falling asleep back there. We need some coffee, Brad. First time in a decade, we've got new hepatitis C therapies. And these medications are associated with the higher chance of curing hepatitis C. Just last week, the CDC gave some new recommendations on screening for hepatitis C. And they drew one's attention to the fact that with hepatitis C, no one carries badges. No one carries badges. So people have hepatitis C for decades and not know they're infected. So what's our aim in the next 40, 45 minutes? Stay awake, right? Right, it's lunchtime. That chicken was pretty good, pretty heavy. We're going to talk about the epidemiology and natural history. In other words, who gets hepatitis C? Who has it? And what happens to patients once they're infected? We're going to talk about the risk factors. And we're going to touch upon current therapies for hepatitis C. Now, here's the hepatitis C virus. Very, very simple structure. But it carries a big punch. People ask me all the time, how come we can't vaccinate against hepatitis C? We could for hepatitis A and B. Why can't we do for hepatitis C? The reason why is that the pink areas, the mauve colors, the envelope proteins, keeps on mutating and changing. Becomes a moving target for the immune system. And that's why we can't develop an antibodies to fight the viral infection. We have antibodies, but they don't work. The virus also codes for a number of enzymes. And these enzymes have all specific roles that enhance the virus ability to replicate. And the reason why I bring this slide up, is that many of these enzymes become targets for therapy. In fact, the targets that have been approved for the past 11, 12 months, work on these specific areas. How do we get hepatitis C? Hepatitis C is a blood-borne virus. Could you get it from hugging? No. Hey, that's pretty good. Kissing? No. How about going to Tito's Tacos? Right? Getting that big burrito? No. No. It's only spread through blood. And the best way hepatitis C, the best way, sharing needles and blood transfusion. And in fact, most people have hepatitis C, got hepatitis C today from sharing needles. But 70% of Americans have hepatitis from sharing needles. Cocaine use, sex with multiple partners. Now how we define multiple partners? Any guesses? More than one. God, you must go to church every Sunday, right? Let me ask Andy over there. All right. So it used to be 25. And now I think that the CDC has said 6 or 7. It's still a lot. Body piercing, dialysis. And dialysis is less of a problem today because blood today is clean for hepatitis C and a number of other factors as well. Transmission during pregnancy. This always comes up. The good news is hepatitis C through pregnancy is very, very rare. 3% of the time, maybe 1% of the time. It's very, very uncommon. Something not up there is tattoos. And tattoos are a risk factor only if people share needles. If you go to this place on Hollywood Boulevard and Sunset, it's probably okay. Right? Oh, you know what I'm talking about, right? Yeah, no, yeah. Well, lift up your shirt. All right. Now, when we have people with hepatitis C, we talk about ways to prevent transmission. And the CDC has provided some guidelines. Like don't, not the biggest thing. Wow, where did this slide come from? Okay, the big thing is right here, third bullet. Don't share toothbrushes. Right? If you got if you start brushing your teeth, you have gum bleeding, you blood on the toothbrush, you share with someone else. Don't share razors if you're infected. And don't share nail clippers. Now, I got to tell you guys, if you ask me, well, how many cases have you heard someone get hepatitis C from sharing a toothbrush or a razor? I've never heard of a case. And these recommendations have been out for over 10 years now. Now this is a very, very important slide. And this slide is brand new. What it highlights is a majority of people with hepatitis C, the majority of people, over 80%, are baby boomers. So the CDC has now said, it's all brand new, only a couple of days old, that all baby boomers be screened for hepatitis C. And I forgot if it's 64 or 65, that's a cutoff. You're born before 64 or 65. 65? All right, 65. Screen for hepatitis C. But over 80% of all cases occur in baby boomers. And I got to tell you, it could have been people, sharing needles in college or high school. Just one time. It becomes a gift that gives on giving. Or transfuse. We have so many women who are 70, 80 years old, right? They got a hysterectomy and got transfusion. Back in the 50s or 60s. Back then, we didn't know what hepatitis C was. So in Los Angeles, we have a lot of people with hepatitis C. Over 100,000 patients are infected here. People use injectable drugs, as high as almost 70% are infected. And in fact, in LA County, more people have hepatitis C than HIV. Screening is very, very easy. Screening is a simple blood test. It's called a hepatitis C antibody. Woo. Hepatitis C antibody, and tells you someone's been infected with hepatitis C. Once the test becomes positive, our next step is to really confirm that infection. And we actually can measure the amount of virus replicating in someone's body, the viral level. Now, like the mafia families in New York, we have 6 hepatitis C families. And we give it a number between 1 and 6. In the United States, type 1 is the most popular, seen in almost 70% of Americans. Genotype 2 and 3 are seen about 20% of Americans. The reason why that's important is that depending on what hepatitis C type you have, you might get treated with different sorts of medication. You might get treated with different duration of medication. And your chance of cure may also differ as well. So when I see someone with hepatitis C, I confirm the infection with a viral load, and I talk about doing a genotype. Now, here's what happens when someone gets infected. Now, if tomorrow I do a liver biopsy, and I get stuck with the needle, ow! Right? And it happens. If I get stuck with the needle, the chance of me getting hepatitis C from the needle stick is about 5%. It's very, very small. If I'm part of that 5%, there's a 60-85% chance that virus will stay for the rest of my life. 15 to 40% it will go away. So I can tell you, I get called by the occupational health at UCLA all the time about house officers, respiratory therapists, nurses, surgeons get stuck with the needle. And I got to tell you, I can't think of one case we've had well, actually, no, we do have one case. But most cases, the virus goes away. I have one patient who was a respiratory therapist, got infected about 9 months ago. Can't say his name, right? It's HIPAA. You know him, though. All right. Focus. All right. So with hepatitis C, there's a chance to go on to cirrhosis 20-50% of the time. Of those who have cirrhosis, there's a risk of going liver failure or developing liver cancer, or both. And many people require liver transplantation. Now, right now, hepatitis C is the most common reason for transplant in this country. 40% of all transplants are performed because of hepatitis C. 40%. And unfortunately, as you know, there's a huge wait list in this country. Now, people with hepatitis C, and again, many have cirrhosis. And people with cirrhosis can do quite well for a long time. But once they have some sign of what we call decompensation, some sign of liver failure, and I'll show you pictures of what that means later, that's when their survival goes down. That means that they could develop ascites, where they're water in their belly, vomiting blood, or turning yellow. And these are the patients we target for transplantation. So I have a lot of patients with hepatitis C, have cirrhosis, and they're doing wonderful. In fact, they wouldn't even know had cirrhosis or hepatitis C if I didn't tell them. Now, this is a study that we published actually last year. And it highlights again the point I made earlier, that no one carries badges. The CDC has said that around 3 million Americans have hepatitis C. 3 million Americans. And we published an article arguing the CDC was incorrect. Is this being taped? No, I'm just kidding. All right, you're not quoting this, are you? All right. So what happens, CDC, when they do surveys, they look at homeless people with hepatitis C? Were 60% of people who are homeless with hepatitis C? No. They go to prisons. Anybody know what proportion of prisoners have hepatitis C in this country? Well, who's a gambler here? Andrew, what do you think? 22%. Oh, that's close. Wrong. 21.4. Nah, 30%. Actually, he's right. It's between 20 and 40%, about 30%. That's a lot of people. A lot of people. Did they look at veterans, active military people, healthcare workers, people on dialysis? Does anybody know what proportion of individuals with hemophilia have hepatitis C? Like 60 to 70%. So these people were not included in the analysis by the CDC. So we think the true hepatitis C prevalence in this country is between 5 and 7 million Americans. If you look at, and again, the most problem with hepatitis C is most people are not diagnosed. The Institute of Medicine last year had a big publication highlighting not just hepatitis C, but all of our hepatitises, that it's really underappreciated. And there's a problem with communication among different healthcare services. Primary doctors are on our screen for hepatitis C, even if the liver tests are elevated. There's a lawsuit recently about a provider who was seeing a patient had elevated liver test for some time, didn't follow up on it. Patient eventually get liver cirrhosis and liver cancer, died. Now, would it made a difference if it was discovered to have hepatitis C 2 years, 5 years ago? Maybe not. But it highlights that we get screen people with hepatitis C, not just based on the liver enzymes, but also based on risk factor. Now, here's a dilemma we all face. There are baby boomers account for over 80% of infections. 80%. Oh my God, so that means that in the next few years, in the next decade, they'll be coming to our offices, not with mild liver disease, but with frank cirrhosis and liver cancer. So many centers, including us at UCLA, Cedars-Sinai, USC, now have dedicated hepatobiliary clinics to deal with this epidemic of liver cancer. It's huge. You guys remember Richard Nixon? Anybody here like Richard Nixon? That's right, no political joke, sorry. All right, so when I was a kid, Nixon, I can't go back. He was like this on TV. I was with my little brother Dennis, and Nixon was on TV like this, looking at beet cancer. His hands were flapping like this, like he was flying. And, he was right. He put all this money in the cancer institutes, and cancer rates have come down in this country. 1 or 2 percentage points. That's a lot. That's a lot. One of the few cancers that have gone up in incidence is liver cancer. Second fastest growing cancer in this country. Anyone know what the fastest growing cancer is? Close. Thyroid. Yeah. It's not thyroid. All right. Stay focused here. This is hepatitis C. All right. So cirrhosis is a spectrum. And I mentioned earlier, people can have cirrhosis, and they have, and it's like I tell people it's like a car that's got dents on it. The car works fine. Got some dents on it. But the function's normal, you feel great. Or you can have cirrhosis that's decompensated. On the other end of the spectrum, and you don't feel great in this situation. You have water retention, like over here. Could you imagine trying to tie a shoelace? Could you imagine trying to eat a lunch or dinner? Or take a deep breath? You can't. I don't know about you guys, but I like sleeping in my belly. They can't sleep on their belly. Here's a page. I don't know if you see this, but that's pretty good, huh? Okay, so there's a line right here. What's that line? It's blood. So people with cirrhosis develop kind of like varicose veins or esophagus, we call varices. And these things could rupture, and it could bleed. People come to my office and say, oh, I had some blood on my pillow. I think I have varicose bleed last night. No. This is a faucet opening up. Vroom, vroom. I mean, it doesn't stop. And then your stool's turned black. Melanoma. Can I go? Oh, here are some physical findings. Liver spots, these red spots on people's chests and arms. Eyes turn yellow. People are so yellow, we turn the lights off, and the lights are fluorescent. No, I'm just kidding about that. These are the veins or esophagus that could bleed, and people can have red palms, called pulmonary edema. The last thing I want to mention, and this is really important, is something called asterixis. So people have cirrhosis. You have to think back about what's a function of the liver, and that is metabolizing, that is filtering. So when you have cirrhosis, you lose those abilities in decompensated liver disease. And so your liver cannot filter out toxins like ammonia. It goes to your brain, and then you get confused. And it's a spectrum. People could have very minimal confusion from liver disease, and when they drive by braille. On the bumps. We had this college professor from Cal State Los Angeles about a year ago. It's about Christmas time. He was really mad. And I go, my God, how long did he wait in the waiting room? I mean, maybe he waited like an hour or something to see us. And he was mad because in the past 2 weeks, he got to 2 car accidents. 2 car accidents. And he had this confusion from the liver disease. Confusion. And this confusion could be so bad that people could be in a coma. We had a patient a couple years ago from Southgate. And this guy, he's in my room, and I knock on the door, and walk in the room, hello, and he's pooping in a trash can. I go, what is this? I go, what do you do in my office? He goes, what do you do in my bathroom? He was so confused. He thought that was his bathroom. So I made him pay $0.25 for that. All right. Okay. Oh, this is really important. So we talked about in Los Angeles that there's more hepatitis than HIV. This is a study that really drives it home. And it emphasizes that we've crossed the line. Since 2006, more people are dying from hepatitis C than HIV. More people dying from hepatitis C than HIV. And if you have someone who's got HIV, what are they dying of? That's right. Hepatitis, liver cirrhosis, and heart disease. So we have someone with hepatitis C, and we talk about therapy. What's our goals? The ultimate goal is to have someone live longer. We had a patient come to us, willed in by his family, 7 years old, hepatitis C. Just got to the hospital with a stroke. Good doctor, he's got hepatitis C. Can you treat him? And I go, we could treat them. But the question is, are we going to make them better or worse? And I tell people that for sure it can make you very sick with therapy. I can't always make you better. So, a big part of our treatment is a liver biopsy. In this picture here, we put a needle in someone's liver, we take a little piece out, put it in a microscope, and we look at the degree of liver damage. Because if someone's got mild disease, and they've had it for 10, 20 years, they need to be treated, but maybe not today. I was telling Leslie about where's Leslie? Wait, Leslie. Look at the camera. Okay. So we're talking about a couple of weeks ago, there was a European meeting of liver diseases. And what they talked about is that the next generation of antiviral therapy for hepatitis C will be all pills, no injections. And we think these pills will be available, God knows when. 3 years, 4 years. It's hard to wait, right? Look at Castro. He's been around for 50 years. We've been waiting for him for a long time to step down. Oh, that sounds bad. All right. This is political. All right. So when people get treated with hepatitis C therapy, it isn't a done deal. Like, when people get their lung infections or urine infections or, they take an antibiotic, they get better. With the hepatitis C, it's a matter of odds. With the previous therapy, the chance of cure is about 50%. But, people might be cured. Other people, you treat them and the virus comes back when you stop therapy. That's always very difficult. Because we thought they were cured. And then went through problems at work, they were on disability, all the side effects, even might have got divorced. We had a patient who got treated once. That was huge. And he started taking his neighbor's Vicodin. And he went home one day, started punching holes in the wall. This guy was big enough he could do that. And the wife goes, "You're out of here." She kicked him out. Okay, we're going with that. All right. So let's get this. Okay. So, we made great advances with hepatitis C therapy. I remember when I was a resident in San Diego about 15 years ago, all we had was interferon. And our cure rate was like 6%. We were so excited. And then about 10, 15 years ago, we started using ribavirin. And that brought up the cure to about mid-30%. And then we changed interferon to make it long-lasting. Instead of 3 times a week shots, it's once a week. We pegylated the interferon, so it lasts longer. The cure went up to 45%. And now, today, the cure rate's between 70 and almost 80%. So 7 or 8 out of 10 people are cured of hepatitis C. Now, can we say cure? I was at a talk in Sacramento last Monday. Don't tell my wife, right? Last Monday. And a doctor asked me in the audience, "Can you really cure hepatitis C?" And he goes, "Wait a minute, can you cure HIV?" I said, "No, you really can't." And he goes, "Well, can you cure hepatitis B?" I go, "No, you really can't either, not usually." He goes, "How can you cure hepatitis C?" The reason is that when the hepatitis C infects a cell, it stays in what's called a cytoplasm. It doesn't go to the cell nucleus. It doesn't become part of the cell. So it's an easier target to treat. When HIV or hepatitis B infects cells, it goes in the cell nucleus and it becomes part of you. And there have been about 8 or 10 papers looking at people treated. And if your viral load 6 months after your last shot is undetectable, and you follow that patient another 5 or 8 years, they have over 95, 99% chance of still being virus negative. That's pretty good. And if you have cirrhosis, there's even a chance we could reverse cirrhosis. If you catch them early enough, right? Someone comes in with yellow eyes, it's treatment, you can actually make them sicker. Or a size guy could kill someone. But if someone got cirrhosis very early, there's a chance of reversing cirrhosis. And if you can reverse cirrhosis, even if you can't reverse cirrhosis, if you cure them, the risk of liver cancer goes down, the need for transplant goes down, the liver will last longer. So this here slide looks at the mechanism of these new drugs, boceprevir and tenofovir. So what happens is when the virus affects a cell, oops, wrong button. Can we go back one slide? Can I do from here? I think I broke this. Oh my God. Oh, there it goes. Oh yeah, right. When the virus affects a cell, it uses a host machinery to make this protein. Poly means many, so it's a polyprotein chain. Well, this polyprotein needs to come apart. And look at the purple thing. That's a capsule. We talked about how that keeps on mutating earlier today. And the brown things that look kind of ugly, they're the enzymes. So one of the targets of the new therapies that have been FDA approved for less than a year now targets one of these proteins. It targets a protein called a protease. Protease is a fancy word for scissors. So go home and try to find out what's a protease. Fancy word for a pair of scissors. And what it does, it cuts the rest of our polyprotein chain. So we can block that enzyme. So the new class of drugs are called protease inhibitors. That's where the name came from. All right. And here's kind of this is kind of a summary slide, not to bore you all, about the cure rates. And the point of this slide is to show how these new drugs, have led to a significant improvement in the cure rates. And one of the most exciting things about these medications is that it helps address major unmet needs in medicine. Major unmet needs. First of all, the overall cure rate goes from 44% to 74% by adding a single medication for the 12 weeks of therapy, first weeks of therapy. If you have someone who's got cirrhosis and you give them 2 drugs, interferon, ribavirin, the chance of cure was 33%. Adding another medication, the cure rate almost doubles. The 2 biggest pools of people with hepatitis C are Latinos and African Americans. African Americans, like people with cirrhosis, have had very, very poor response to medication. Major unmet need in medicine, major. By adding another medication to their cocktail, the chance of cure over doubles. Now, we've got a long ways to go still, right? But it's a step in the right direction. I mentioned earlier that with the previous therapy of interferon ribavirin, about 45% chance of cure. Here's just 44%. Well, what do you do with those patients? Shake their heads, I'm sorry. People need options. And the addition of tenofovir in this slide here increases the cure rates for people who are relapsers, for all non-responders. Its cousin drug, boceprevir, the results are equally exciting. Across the board, it's improving the cure rates. Overall, people with advanced disease, African Americans, and people who are non-responders. Treatment is pretty difficult. When we think about therapy, we got to think about, how much liver disease they have. I showed the picture of the liver biopsies, their genotype. Have they been treated before or not before? If you have someone who's been treated before, and they go, doctor, I want to be treated again. Well, how'd you do last time you got treated? Horrible. I became suicidal. And it's like that movie you guys seen the movie Titanic? Andy has an iPad. Show it, Andy. Okay. It's like the Titanic, right? If the boat's sinking, right, you got to forget the beach chairs. You got to save yourself. And so same thing with hepatitis C. If someone's having horrible side effects, You got to forget the virus. Just save the patient. So people who've had very serious side effects before, suicidal, severe depression that we couldn't control with therapy, those are the ones that really need to hold off for other drugs to come out, and again, in the next several years. Right now, the Liver Society says that the interferon is really a treatment of choice with pegylated ribavirin. These new drugs, tilapia and bocephor, cannot be used by themselves because there's always a chance of resistance. So, you can see this. Okay, it's pretty good. So this is I just showed this slide to show you that treating hepatitis C, there are different algorithms and strategies. With hepatitis C, some people may only need 6 months of therapy if they're genotype 1, if they have a rapid viral response. Otherwise, they need 1 year treatment. And people who have partial or non-responders may need a whole year of therapy. Cirrhosis need a year of therapy. Bocephor, it's a little different. There's what's called a lead-in phase, where you do 2 drugs up front, and after a month, you add the protease inhibitor. So the strategies are a little different between the 2 medications. Now, most of the side effects are still due to interferon ribavirin. Interferon is a shot you take once a week. It causes flu-like symptoms. Myalgia, muscle pain, joint pain, depressed mood, nausea. May spark, the thyroid to act up. May cause bone marrow problems. Hair loss. That's a big issue for many of us. The other medicine we use, ribavirin, has its own set of signature adverse effects. The biggest thing is anemia. About 15 to 20% become anemic on therapy because of cough, shortness of breath, rashes, insomnia, and equally important, may cause birth defects. So people on hepatitis C therapy, they cannot get pregnant during the course of therapy or for 6 months afterwards. Now, one of the new issues for us in hepatitis C is the issue of resistance. And what happens is these drugs are so potent, they're so effective, they're so powerful in cured hepatitis C that if they're not working, you're getting resistance. And if you get resistant to one of the medications, you can't use the other one because it means you're resistant to both medications. Here's a slide looking at this is an example of tilapia, the side effects. And the biggest side effects we see in tilapia is a skin rash, anemia, a third of patient, and the ring of fire. Anyone know what the ring of fire is? You may know. It's anal rectal rash. So you get hemorrhoids act up, you get burning, and pain. And this can happen within 4 days of starting the medication. 4 days. The other new concept besides resistance for us in hepatology is the idea of drug interactions. And what happens is these new medications interact with other medications. For instance, if you have someone who's got a high cholesterol, and you give them tilapia or bocephor, it may raise the level of the cholesterol medication and cause serious side effects. It also may lower other drug levels, like birth control pill. So birth control pill becomes obsolete as a way of preventing pregnancy. Another issue is effectiveness. Now, like everything else, if it isn't working, we want to stop it, right? Drugs are expensive, have a lot of side effects, and there's other options later on. So if it isn't working, we want to stop it. So the FDA has put a number of what they call futility rules, stopping rules, that if you don't reach certain milestones, you got to stop the hepatitis C therapy. Resistance. Okay. Now, this next couple of slides are what to expect for hepatitis C. And this is very, very exciting. Are you guys still awake back there? All right, someone's nodding off. All right. All right, so this is a study published 2 years ago in Lancet, and it's called a proof of concept. It showed for the first time ever, using 2 pills, the virus becomes undetectable. 2 pills. This is another study from Germany showing the exact same thing. This study here, went further. And they looked at patients who were no responders. These are people who've been treated before, and it didn't work. It didn't work at all. When you treat them with interferon virus, the viral load flatlined. Never went down by an inch. By giving these people 2 medications in the far slide, the viral level did go down. After a while, the viral level would come back up again. So, another part of the study was these 2 oral drugs plus interferon ribavirin. And they found that every single patient was cured of hepatitis C. It's a major breakthrough. So it may be that, there's a slide. It may be that we may be using all oral therapies for many of our patients, maybe most of them. But there may be some segments of patients who still need an interferon. This is fresh off the press. This slide here is based on a meeting, again, we had several weeks ago in Europe. And look at these numbers. The first column are the companies that support these trials. Second column is the name of the study. They got some weird names. Atomic, Electron. People are paid millions of dollars to think of these names, by the way. That could be you. They looked at population, so they're naive. That means they've never been treated before, or people been treated before, it didn't work. The fourth column is what they got, what they received. The fifth column, look at this. How long they're treated for. My God, 12 weeks of therapy. 28 weeks of therapy. And the last column is a cure rate. So if we look at the first row, Abbott, the co-pilot study, naive patients using 2 enzyme inhibitors plus ribavirin for 12 weeks, over 90% chance of cure. 93 to 95%. If you look at the third row, using 2 oral drugs, a protease and a polymerase inhibitor plus ribavirin for 28 weeks, chance of cure is 82% overall. If you have cirrhosis, 70%. That's higher than we see today with interferon ribavirin and telaprevir and boceprevir. Yes? Good question. So it's all genotype 1. Thank you for asking the question. And look at the last row. You guys look at the last row. Electron study. 2 pills for 24 weeks. Genotype 1. 100% cure. Now, to be fair, balanced about this, one thing that's missing from this slide are the number of patients. So the next draft a number of patients. Most of the studies are very small, 10, 20, 30 patients. I think the third row had about 90 or 100. That's a big study. But it's very, very exciting. So we anticipate, in the year 2014, we could maybe have other options for hepatitis C, and maybe an all-oral therapy combination for genotype 1, like Leslie asked, probably 2015. Now, Leslie, it's possible that late next year, we may have only oral therapy for genotype 2 and 3. So I'm glad you asked that question because it may affect everybody. How do you keep your liver healthy? No alcohol. You guys know that, right? We had a patient at UCLA a couple of years ago, came in with cirrhosis. And she told the doctor, I drink occasionally, a glass of wine. Oh, that won't do it. So I asked her, how big is your glass? Oh, this big. I said, well, it's like a half a liter a day. Well, there you go. That's your cirrhosis. No alcohol. Because, it's good for the heart, right? The other thing is coffee is good for the liver. I don't know if you saw, there was last week on the internet, there was in the LA Times talked about coffee good for living longer. People drink coffee on a regular basis live longer. good for dementia, good for heart disease, good for hepatitis C. Actually, data from the NIH showing if you drink coffee, your hepatitis C progresses much more slower. And the last thing that I didn't touch on, that if you have someone who's got hepatitis C and they've never had hepatitis A or B, they should be vaccinated. Because if they get hepatitis A and or B on top of hepatitis C, it could be very dangerous. So, the moral words, Dr. Seuss, will you succeed? 98.75% guaranteed. And we'll move mountains. Thank you for your attention. And great, thank you for all the great work you guys all do. I guess we have time for a couple questions. A few questions? Yes, sir.
My name's Bill Preston.
Hi, Bill.
Thank you for a great presentation.
Oh, thank you. My first talk.
Oh, first time.
Yeah, I'm a little nervous. I took a little battling before I got here. I got a patch on my back. Sorry.
Yeah, I worked in the pharmaceutical industry for many years.
Yeah.
Oh, you want to come? Oh, yeah, I'm sorry. My one question, the thing that really that I struggle with is I see, the fact that there could be these very effective tools, that rapid hepatitis C tool for OraSure.
Yes.
The same thing with HIV. So
Yes.
I'm just hoping at the primary care setting, if we can get control of this and get the patient on the treatment earlier on, will there be a follow-through on that at the primary care level, working in concert with you all? Because otherwise you're fighting an uphill battle.
So the question is about once you diagnose someone with these screening tests, what's the next step? And that's been a major barrier in terms of diagnosing hepatitis C is what's the next step. So you got 100% right. I agree with you. We need to have an out. Some kind of resources to educate patients about issues about alcohol, coffee, and stop smoking cigarettes. But what access do we have for treatment for their patients? There's a lot of options. But the problem is getting the message out there. But you're right. We need the next step to know what to do after diagnosing someone with hepatitis C. Yes. You're welcome. Yes, ma'am.
Yeah, what really determines what genotype it's going to be? I don't know if this is a myth, but I had heard that geographically there are clusters of certain types of genotypes in cities and countries. Is that true?
There's a great clinic at south of the border that can change your genotype. No, I'm just kidding. So, okay, so the hepatitis C genotype, I got this great question. We don't know why that is. You're 100% right. So we tell people it's a hepatitis C virus you get infected with. But it doesn't make sense because people first use drugs or have hemophilia or transfusion may have got more than one transfusion. So they may be exposed to more than one genotype. It turns out that the most powerful one is genotype 1 and overshadows everything else. So generally, if you have genotype 2 and 3 and you didn't get any other genotypes, you stick with that genotype. I suspect if you get genotype 2 and 3 and you get genotype 1 after that, genotype 1 overshadows everything else. So unfortunately, it's the one we tell people they get when you first get infected. With these new, and it makes a big difference in terms of duration of therapy and what have you. But the cure rate for genotype 2 and 3, using just 2 drugs, is about 70-80% for 20 weeks of therapy. It's a big difference. And in the future, we might have just pills for hepatitis C genotype 2, and the response rate may be as high as 100% with just pills. That may be 1.5 years, 2 years away. Yes, sir.
You mentioned a little bit about HIV and hepatitis C co-infection, but currently the drugs that are approved for treatment of hepatitis C, there really aren't options for individuals who are co-infected. Can you speak to sort of what's on the horizon for them?
Great question. I should emphasize a little more, a little better. 30% of everybody who has HIV has hepatitis C. And if you look at the top killers of people with HIV, it's not tuberculosis. It's not meningitis. It's not PCP. It's not muscle wasting. It's heart disease and liver disease. And so recently there was a meeting in Seattle where they presented data in abstract form using new drugs in HIV co-infected patients. The results were astronomical. The very similar cure rate you see in mono-infected patients, you see with co-infected patients as well. The barriers is what you highlight, is that these drugs are not FDA approved as of today in co-infected patients. They will be, though. They will be, though. It's been difficult because of the drug interactions. So when we have patients who we treat are co-infected, we work a lot with their HIV doctors, our colleagues, and go, listen, he's on drug X or she's on drug Y. We put him on a different drug. because the drug interactions may limit the efficacy and may cause resistance to HIV drugs or resistant my drugs. So in select cases we have been treating off-label, they have to really mirror therapy. They have to have very advanced disease. Good question. Yes.
When you talk about relapsers,
Yes.
are those ever cured and then they relapsed, or?
So let's go back to that slide. Close your eyes. You have a seizure. Close your eyes. So relapser means that that someone got the hepatitis C. Oh my God! How many? All right, so someone got treated, and then the virus went down to 0 or undetectable levels during therapy. But when you stop the medication, the virus comes back, and if it comes back 99% of the time by 3 months. By 3 months. So the FDA appreciates that, and the FDA is saying that for clinical trials, they're going to start using data at 12 weeks instead of 24 weeks after the last shot, because the virus comes back by 12 weeks, by 3 months, and that's nice because it's going to make these drugs be approved much faster. Thank you. Yep.
Yeah, in your data and treatment, are the children are included?
No, so good question about children. So there are some limited data on treating hepatitis C in children. To the best of my knowledge, and I'm not a pediatrician, but the best of my knowledge, the response rate are very, very good. I'm not aware of any trials using telaprevir boceprevir in children. I don't think, only interferon ribavirin. They seem to tolerate better. As we get older, the side effects become more and more with these antiviral therapies. Treating someone who's like 20 years old or 15 is very different from someone who's 65 or 70. Very different. They tolerate much better. I know. Hey, those are tough issues, and I probably defer to my pediatric, liver doctors for that. Thanks, good question. You gotta run faster. Yep. Faster. Run! Look at that song, Meet Me Halfway.
Hi, I have a question, and I might have missed this since I came in late. But the non-interferon drugs, do those work for post-transplant patients?
So, wow, good question. The question is, the drug, the ones that were presented recently, or telaprevir and boceprevir?
No, the non-interferon drugs.
Well,
okay, or let's go back and talk about the protease inhibitor drugs.
Where does this slide come from?
I have another question.
So the answer is yes, they do. They're not indicated by the government, the FDA yet, because the biggest concern are drug interactions. So if you have someone who had liver transplant and you give them, for instance, telaprevir, it could raise levels of immunosuppression like Prograf 70 times, cause kidney failure, cause seizures, even high blood pressure. So we have been treating people, select patients. We have a strategy that our nurse at UCLA developed, switch our immunosuppression around, and then get daily blood tests for about 10 days. And I got to tell you, we've been using this off-label, not indicated in the United States, and we've had a very good success rate. Almost every single patient responded. But we need more data. We need more data. Great question.
Well, then, to follow that up then, do they know yet on the non-interferon drugs if those could be used for post-transplant patients? So because you were just referring to the boceprevir and telaprevir, correct?
So the other ones, no. What happens when drugs are first approved, they're always approved when the people are easy to treat. So that's why most trials don't include anyone who has cirrhosis or advanced disease, because the more damage you have in your liver, the harder to treat someone.
Do we have time for one more?
One line, yes, of course.
Of course, I have to run
if
all the
I
way.
get a ticket, racing.
I just wanted to see you run across the camera. All right.
Go around.
I'm concerned about those who are still dealing with their recovery issues, and I know that none of the data is really focusing on that. But I'm concerned that if they are taking a drug and they're triggered by the needles, and they're going through suicidal thoughts, they oftentimes will relapse to a coping mechanism. Is this data actually reflecting that? Are they dropping out or not responding because of relapse substance abuse?
You know what? It's a real issue. So I have a rule of thumb that I prefer not to anybody who's used needles within 6-12 months for the issues you brought up. I'm not aware of any hard data in the literature, but most providers are concerned about that issue. these new drugs have not been studied in that setting. It may be, when we have the oral drugs, that might be a great opportunity to treat people like that, because it won't come back to the memories of using needles and et cetera. But those are very important issues. And unfortunately, we don't have much data on that. So at this moment, thank you again for coming today. And thank Brad for inviting me to speak on a very important topic. Thank you, everybody. Thanks for inviting me again, Brad.
Thank you, Dr. Saab, one more time. Very quickly, we would just like to do a brief overview of the Partnership for Prescription Assistance Program. Like I said, it's on the right side of your packet. It has the PPA logo up on the left side. And we have John here from the PPA team to talk about this fantastic program. John.
All right. How's it going, everyone? I know everybody wants to get out of here, so I'll be pretty quick. Most of the information is on the piece of paper that Brandon talked about. I'm John Winger. I'm with the Partnership for Prescription Assistance Program. I do the Southern California outreach for the program. Basically, the Partnership for Prescription Assistance is a partnership between doctors, pharmacists, healthcare providers, healthcare advocates, local civic groups, basically anybody that's dedicated to helping patients find the medications to fit their needs. Since 2005, the Partnership for Prescription Assistance has helped over 6.5 million people. Most of those people are either uninsured or underinsured. There's roughly 475 public and private patient assistance programs out there in the nation. What we do is we bring all of those programs into a single clearinghouse. It's basically a website and a phone number that you can use, and the patients basically can come to the website or come to the toll-free number, which is both on your piece of paper, and find out what programs they may qualify for by simply giving some basic information about themselves. It's all HIPAA compliant. It's all confidential. Out of all the programs, it covers around 2,500 brand name prescription medications, along with hundreds of other types of generic medications as well. The website, which is pparx.org, also has other resources for the patients. We have a load of free healthcare clinic finder, so they can basically put in their zip code and find what free healthcare clinics are next to them to help get their provider to sign the proof of prescription and get enrolled into a program quickly. You can also download the forms off of the website very easily. But we do have a toll-free number if you don't have regular internet access. Takes a little bit longer to get the forms and get them filled out and get approved, but once you get the forms filled out and sent in, usually takes about 2 to 3 weeks to get the prescription medications. The majority of the programs either cover 100% of the cost or half the cost. Really depends on the program. Like I said, there's 475 different ones out there, so it really depends on the patient's needs. But what we're doing is creating a single point of access for consumers and for patients that need this valuable information. And so what I do is I obviously attend these CPAT events, give my little spiel about what I do and what the program is. I also give presentations to your organizations, teach you how to go through the website, how to go through the process of online. I also attend healthcare events, pass out information to all the people that you try to reach. And so I am pretty much here for your guys' disposal. Are there any questions about the program at all? Everybody I see a lot of familiar faces. So. No? All right, that's about it.
Thank you, John. That concludes our presentation. I want to thank Dr. Saab. I'd like to thank John. I'd like to thank our co-hosts. I'd like to thank all of you for coming out. I think the central message is awareness and early detection are the key. So hopefully that when you go back to your organizations as you're dealing with your constituents, you will tell them to make sure they get themselves tested. We hope to see you at a future CPAT event. Thank you so much for coming once again, and everyone have a great day.